everyone listening, please, if you have a question, this is a world expert, and you'll never have a chance to have a one-on-one like this. So make your questions, put them in the chat, and we'll see if we can get to them. And so without further ado, Dr. Kishan, it's all yours.
Well, thanks so much for the invitation. Happy to see so many of you here. I'm going to be talking about SBRT, or stereotactic body radiotherapy for prostate cancer, and specifically the role for MRI guidance. I put together a couple of slides, so I will share them here. And please feel free to ask any questions. You can either use the chat box and send something during the talk, or we'll have time for questions afterwards as well, I'm sure. Let me just put on the presentation view here. Okay, so here are my disclosures. So as I mentioned, we're going to be going over the rationale and evidence for SBRT in general. This is something that I'm asked about frequently. And then we'll talk about a newer development, which is MRI-guided radiotherapy, also going over the rationale and evidence for this as well. And I apologize, my voice is not coming out fully clearly. I'm just getting over a cold. So just to make sure everyone's on the same page, and I know many of you are already very well aware of this, but EBRT, or external beam radiotherapy, is referring to the use of high-energy X-rays that are directed towards the prostate by a linear accelerator. Patients that are treated with this form of treatment are not radioactive. There's no heating or burning involved. It's a completely non-invasive procedure using high-tech devices. And you can see on the left of the screen an example here of the MRI-guided device, which is the Meridian, which we have at UCLA. As well as another type of platform called the Novalis TX, another type of linear accelerator that's used for CT-guided radiotherapy. So what are the different types of EBRT? Historically, EBRT has been delivered in the form of multiple daily doses of radiation over a certain time period. We've learned over time that prostate cancer is uniquely sensitive to a higher dose of radiation per day, which has allowed the investigation of shorter and shorter treatment schedules. So conventional fractionation, you can see in this table here, is the use of 1.8 to 2 gray per day over 39 to 45 total treatments. That's 8 to 9 weeks of therapy. You might hear people refer to this as IMRT. IMRT is intensity modulated radiotherapy. It's actually very specifically a type of radiation planning that should be used in all cases, actually. So technically, all of these are IMRT. Conventional fractionation is the long course of radiation, but sometimes those terms are used interchangeably. Moderate hypofractionation is kind of an in-between. It's 2.5 to 3 gray per day, total of 4 to 5.5 weeks of radiation treatments. That's about 20 to 28 treatments. And then we have SBRT as kind of the ultimate in kind of compressed radiation schedules, 7.25 to 8 gray per day. So you can see it's a substantially higher dose per day, about 4 times the dose of the conventional fractionation, but it's only 5 treatments. These are typically delivered every other day. So we're looking at 1.5 weeks, or about 10 days of radiation total. So, what is SBRT? It's stereotactic body radiotherapy. Sometimes people use the term SABR, stereotactic ablative radiotherapy. It's a form of advanced radiation technology where high doses of radiation are delivered over 5 or fewer treatments. In prostate cancer world, it's typically 5 treatments. There are some regimens that are 4 treatments, but generally 5. But more generally, any treatment, 1 to 5 treatments, is considered SBRT, as long as you're using advanced imaging and delivery techniques. Now, there are many different platforms for delivering SBRT. These are all acceptable. They're sometimes referred to by brand name like CyberKnife. That was the first system used to deliver SBRT, but it's actually just a brand name. The SBRT and CyberKnife are not interchangeable. You can use SBRT with any of these other platforms. I mentioned Novalis TX, one of the machines we have here. TrueBeam, another very commonly used platform, and then the Meridian, which is the MRI-guided radiation device that I'll be talking about for MRI-guided SBRT. So, what is the evidence for SBRT? It's now considered a standard of care option for prostate cancer management in the US. And so that's important. As of 2022, it's definitely standard for all risk forms. It's supported by multiple lines of evidence, and I'll go over these not in incredible detail for any single study, happy to answer specific questions afterwards, but more just to give a broad view of the level of evidence that's existing to support SBRT. The first major study was the hypo-RT-PC trial. So this is a randomized trial. In medicine, the gold standard is a randomized study where the doctor and the patient can't choose what treatment is being delivered. That's the only way to prove that, you know, either one treatment is better than another or that they're the same, is to actually use a randomization, which is why this was a major deal and was published in 2019 in one of the world's best medical journals. This was run out of Sweden, and men were randomized to either get conventional radiation, the 8-week course of radiation, or something called ultra hypofractionation. Now, in Sweden, they didn't have the rule that SBRT had to be 5 treatments. They were actually just using older planning technology and delivering a high dose per day over 7 treatments. However, functionally, it's the same as what SBRT is in the US that I'll be talking about. So this is really a study of SBRT type dosing. Again, randomized against a long course. What did it show? Well, if you look at this graph, this is looking at failure-free survival. The red line is people getting the SBRT-like treatment, and the blue line is the long course radiation. They're completely overlapped.
Join the meeting.
Okay. So, you know, these are completely overlapping. So there's no difference in cure rate. Failure-free survival is the chance of a recurrence and, you know, the chance of being alive, only because, you know, sometimes when, you know, older patients are treated or they have some other medical condition, they might pass away of another cause not related to prostate cancer. So that's why they combine the two here, but there's no difference at all. So completely equivalent. There's also no difference in late side effects. So it really provides gold standard evidence that SBRT type dosing is equivalent to the long course radiation, again, in a randomized trial. This was replicated in a study called PACE-B out of the United Kingdom, which was also published in a high-tier journal in 2019, so pretty recent. Another randomized trial. Here, they compared SBRT proper, the 5 treatments, against a mix of either the long course, 8 to 9 week course, or the moderate hypofractionation, which was 4 weeks. In the UK, they were very quick to adopt moderate hypofractionation. So actually, most of these patients on the control arm of that study got the 4 weeks of radiation. What did this show here? You see a graph looking at acute side effects, short-term side effects. I'll draw your attention to the dots. The red dots are grade 1 or very, you know, mild, minor side effects. And the red is going to be the conventional or moderate, so the control arm, and the blue is the SBRT. No difference in either bowel or bladder side effects. They peak, you know, about a month after the radiation and go away in both cases, largely returning to normal. You can see that for more severe side effects, shown in the triangle, they're very rare no matter what type of radiation is being used. And these more moderate side effects, which is shown in the squares, are also similar between either SBRT or the longer courses of radiation. So again, providing high-level evidence that SBRT is, you know, safe and effective in the modern setting. And now our group here at UCLA decided to do another study, not a randomized study, but a study saying, well, look, we've treated so many patients before these randomized trials with SBRT in North America. Why don't we look and see how these patients did in the long term? So we went back and we found 2,132 patients that were treated with SBRT from 2000 to 2012, where we actually had a long-term follow-up. What we were able to see is, you know, measuring the effectiveness rate into long-term. The 7-year cure rate for these men was the 7-year recurrence rate.
Right, you got it.
There's a lot of non-muted mics, unfortunately. So the 7-year biochemical recurrence rate is about 4.5% for patients with low risk prostate cancer. For intermediate risk favorable prostate cancer, 8.6%, and unfavorable intermediate risk, about almost 15%, with SBRT without hormone therapy. So again, this is not a randomized trial. This is just looking at a large group of patients that were treated with SBRT over a long period of time. So it gives us long-term data showing that it's very, very safe. And if we look at the toxicity outcomes, the reason I'm showing this graph here is because it puts it in picture form. So what you're looking at here is severe urinary side effects. these in the dark blue boxes here is longer courses of radiation. This here would be brachytherapy with permanent seeds, or brachytherapy with a temporary seeds. This is the brachytherapy boost treatment in orange. Here is another type of brachytherapy boost, and then the moderate hypofractionation, which is the 4-week course of radiation. And here's SBRT on our study. And one of the major issues with widespread adoption of SBRT was the concern that this number would be way out here. It would be causing a lot of side effects to give a high dose per day. Instead, this is actually very favorable. It's even lower than these other numbers for the large part. Again, this is not a randomized study, but the 7-year rates of severe urinary toxicity was about 2.4%. Granted, that's not zero, so side effects still occur. No one is saying that they don't, but that number is no higher than with any other form of radiation, possibly even lower. For example, if you look at some of these forms of brachytherapy. And similarly, we see the same pattern for GI side effects or rectal side effects. Very rare, 0.4% at 7 years, and this large study of patients that received SBRT. So, sorry, there was a question in the chat, but I think it was just a comment about muting. So for another study that we did, we wanted to actually look at high-risk prostate cancer. It's something I'm asked about very frequently. The previous 3 studies that I showed were in majority focused on intermediate risk disease. And in the UCLA study, there was a number of patients with low-risk prostate cancer. What about high-risk disease? SBRT for high-risk prostate cancer is considered standard of care. There were some men on the Swedish trial that I showed that had high-risk prostate cancer, but we wanted to do a more focused appraisal of this. And so we looked at 344 men that were treated on 7 trials across the world. This was relatively recently published in 2021, just to see how effective was SBRT. And what we found is very high cure rate. So again, here is the failure-free survival, like I had shown for one of the other studies. If you look at this gray line, that's everybody that was treated. At 4 years, 82% of men are free of disease without any recurrence. Okay, if you factor in hormone therapy, that number goes, this is the blue line, patients treated with hormone therapy and as well as SBRT, that number goes up to about 87%. If you omit hormone therapy, it does go down. But overall, these are very, very favorable outcomes. They're on the order of the brachytherapy boost treatment, which is a highly effective, well-studied treatment for prostate cancer. And is part of why SBRT is considered a standard option for high-risk disease. We offer it to everyone that we see that's a good candidate. So again, it is inappropriate to use this modality for high-risk prostate cancer. So how is SBRT delivered? I think the most important thing is to realize that the prostate is a moving target. Here's the anatomy. You can see the prostate here. The urethra is a tube running through the center and out. The bladder on top of the prostate and the rectum behind it. As the bladder fills up and empties, as the rectum fills up and empties, the prostate is going to be moving back and forth, up and down, and a little bit left and right. And we've actually measured this motion using some imaging studies. In the span of about 2 to 3 minutes, the prostate is moving back and forth about 3 millimeters, up and down about 3 millimeters, and left, right about 2 millimeters. That's, a very small amount on the one hand. On the other hand, we need to be very precise here. We're delivering high dose radiation to pretty important space, right? There's the bladder right there, the rectum right there. Precision is important on the millimeter order. So because of the fact that the prostate is moving, you have to balance that with the fact that you don't want to overdose the bladder or rectum nearby, but you want to hit the prostate as well, right? There's no point in doing this if we miss the target. So always when external radiation is delivered, whether it's SBRT or a longer course of radiation, you put a margin around the prostate. So for example, we would treat not just the prostate, but like a 3 to 4 millimeter cell around it. So we capture that motion that happens. We're not missing the target. Of course, if we're treating a 3 millimeter, 4 millimeter cell around the prostate, that means parts of the bladder, parts of the rectum are going to be exposed to radiation because that's just a part of this treatment. Okay, but that's an important consideration with SBRT. So how do we manage this with CT guidance? The prostate is not easily seen on a CT scan. That's why when someone is diagnosed with prostate cancer, for staging purposes, an MRI is obtained. An MRI gives you a much better picture of the anatomy of the prostate. So with CT-guided SBRT or CT-guided radiation in general, we don't want to use a CT to target the radiation. We want to have a better marker of tracking the prostate. So we use fiducial markers. These are metal markers that can be placed into the prostate. It's a small outpatient procedure. They're put in transperineally, so the skin between the scrotum and the anus. An ultron probe is in the rectum to help locate the prostate, and then 3 pokes of a needle through the perineum to put these markers into the prostate. They're metal. They're inert metal. They don't cause any radiation. They're not radioactive, but they will show up on an X-ray. Metal will always show up on an X-ray. And so in this workflow, these markers are placed into the prostate. And then when a patient is getting treated, we get a scan beforehand to make sure the anatomy looks good. And then we use these paired X-rays to target the markers. We're tracking the markers inside the prostate, not the prostate itself, but it's an effective and time-tested way of delivering the radiation. Okay, so that's what we do with CT-guided SBRT. What are the limitations? Well, as I just mentioned, the prostate is best seen on an MRI. And in fact, it's so much better seen on an MRI that even when we're designing radiation, even when I'm designing a CT-based radiation plan, I use the information from a diagnostic MRI. I fuse that to the CT scan I get for mapping the radiation, and I use that to design the treatment. And not just me, that's a standard practice. Okay, but anytime you're fusing an MRI to a CT scan, there's a little bit of uncertainty there. They're not the same type of image. So in addition to the margin of uncertainty you need for motion, you also are introducing some uncertainty because of all these different images that are being used to design the treatment plan. So that's one limitation. Another limitation is it's invasive. Obviously, you know, if you can avoid an invasive procedure, you would like to do that. There's a minor risk of bleeding, you know, pain, infection. It's not a pleasant thing to have these markers placed. Even if there is real-time monitoring that's performed, it's not truly real-time just because of the technology that's being used. We're talking about imaging something once every minute to 2 minutes, which is certainly good, but it's not like it's all the, you know, the prostate is moving more quickly than that as well. So it's not fully able to account for the motion of the prostate. And then this is a kind of relatively minor thing, but anytime you're doing these X-rays, there's some radiation exposure. You know, it's not zero. It's a pretty low number, but like, for example, if you're doing a long treatment and getting a ton of X-rays during that treatment, there is some dose coming from the X-ray images as well. So there's some exposure to ionizing radiation from the treatment guidance. So this is where the idea for MRI-guided radiotherapy comes in. What is this? MRGRT, MRI-guided radiotherapy. It's an advanced form of radiotherapy in which an MRI is used to direct the radiation. Historically, this has not been possible due to physics-related complications with combining a magnetic field and a linear accelerator. So it's just not been something that could be done. Now, thanks to some technical innovations, these are available for use finally, MRI-guided linear accelerators. There are 2 commercially available platforms. At UCLA, we use one manufactured by Vuray called the Meridian device. We installed that in late 2019 and have been using it since 2020. As an academic center, you know, we have taken the approach that it's important to really carefully study this, to quantify what the benefits are, how best to use this device. And as such, I have run clinical trials using this machine. But that's because, you know, our mission is to do science, to try to improve care and do research and all that kind of stuff. That doesn't mean these aren't FDA approved. These are absolutely FDA approved. You can be treated on one of these as a standard of care. The only reason we do trials at UCLA is because we're trying to expand the use and understand the treatment a little bit better, maybe innovate ways of doing things that you couldn't get certainly MRI-guided radiation off of a clinical trial as a standard of care option as well. So what is the Meridian unit? It's a linear accelerator, as you see here, that has an MRI built into it. One distinction from the CT-guided radiation, most CT-guided radiation platforms, you're not inside anything. You're lying on a table and a large machine is rotating around you. In this case, you are actually inside of an MRI chamber during the radiation. That's part of it. That's actually a major part of why it's beneficial. You have that MRI to help guide the treatment, but it does mean you are actually inside something. The MRI that's here is a 0.35 Tesla MRI, so it's not, a 3 Tesla MRI. It is safe to be integrated with the linear accelerator. We use a we use an MRI obtained on this machine as part of the radiation planning. So that means when we're, comparing an MRI that you might have gotten for diagnosis, we're overlaying an MRI with another MRI. It eliminates some of the uncertainty that I had mentioned before. We also are using that MRI to do the initial patient setup, which has very good image resolution for targeting the radiation. And I think most intriguingly, we're getting MRI images 4 to 8 times per second while someone is being treated, and also a video of that. But that allows you to really track the prostate very closely. As I mentioned, it is a moving target. It's not staying still. So what are the benefits here? Well, you're directly contouring on an MRI image. There's less uncertainty, especially if you're bringing in a second MRI image to try to draw things. There's no issue with using different imaging modalities. You have the real-time monitoring that's very frequent, 4 to 8 times per second. You don't need the fiducials to be placed. You're aligning to the prostate directly, not to these markers that are indirect, proxies of prostate position. And again, it's a low issue, it's a minor issue, but there's no radiation dose, right? There's no imaging dose because an MRI does not deliver radiation. So all the imaging that's being done is free of ionizing radiation exposure. So just as an example, because I think a picture kind of tells us a little bit more closely, here's a side-by-side comparison of what the prostate looks like on a CT scan versus on an MRI. It's clearly more visible on the MRI than on the CT scan. Actually, here, this magenta is an outline based on the MRI, and the green is an outline based on the CT. That's clearly a larger area that would need to be treated if you're just going based off the CT-based contour. This is why many of us that do CT-guided SBRT still get an MRI, like a diagnostic MRI separately, and try to overlay it and do our best to contour using the MRI information. It's just a better picture. However, again, there is some uncertainty when you do that as opposed to directly contouring on an MRI scan. For what the motion, again, worth, I think, talking about this a little bit more detail. MRIs are obtained 4 to 8 times per second, with the radiation beam being paused automatically if the prostate moves outside a preset margin. So let's say we put a 3 millimeter safety margin around the target. If the prostate moves, say 10% of it moves outside of that margin, the beam turns off. If it turns off for more than 120 seconds, you need to manually restart it. And that usually means, we have to assess it, make sure there isn't some, anatomical change or whatever. And that really allows you to be very precise, because now you're very closely monitoring it. A large portion of that margin that you need to add for motion, you can take care of. You can really reduce that margin because you're monitoring things so closely. And again, here's an image, because I think a picture can demonstrate this better. So just to orient you, this is the bladder, here's the rectum. This is the safety margin in yellow, and in red is the prostate and the proximal seminal vesicles, which is the target. You can see here something that says target in, and keep your eye on that as well. But if you look, you can see that a gas bubble is going to come and move the prostate out of that gating margin. And when it moves out, the machine turns off automatically. Now, that happens much more rapidly than once per minute, right? This image is actually a pretty short period of time when this is occurring. So that's why imaging 1 to 2 times per minute, that's very frequent, but it's very different than imaging 4 to 8 times per second, which is what this is doing. And that difference really allows you to be very, very precise with your treatment without worrying about missing. You're really very closely looking at things. So long story short, as I mentioned, our goal is to, prove that these things are better. These are lots of really nice ideas for why it might be better. And for a lot of people, that's enough, right? They'll buy the machine and use it. But we wanted to prove that it's actually better. And so we ran a randomized trial. Like I said in the beginning, a randomized trial is what's required to prove something is better than the other, and that's the highest standard in medicine. So we did that. We did a trial called the MRI-guided trial. And from May 2020 through October 2021, if I was seeing a patient that was a candidate for prostate SBRT, I wasn't just offering them treatment on our device. And I'm sure that annoyed some patients, but it was a randomization. We would only treat on this trial, basically, if you signed up and you were randomized to receive ViewRay or Meridian-guided, MRI-guided SBRT. And so it's a straight randomization, which allows you to make a very clean comparison. And so after the first 100 patients were treated on that trial, roughly 50 per arm, we did what's called an interim analysis, meaning we looked to see if we were finding a difference. And if we were finding a difference, we were going to stop the trial. And here are the results, as you can see. So in blue, these are the percentage of patients experiencing moderate here urinary toxicity, and here on the right is moderate bowel or GI gastrointestinal toxicity. Blue is the CT guided SBRT. Red is the MRI-guided SBRT. There is a dramatic difference. So 47% of patients had moderate urinary difficulty toxicity with CT-guided SBRT. Dropped that to 22% with the MRI-guided SBRT. For bowel, 14% to 0% with the MRI-guided SBRT. Those are huge effects. And so after I saw this data, I closed the trial. We're working on presenting and publishing the final results that will come out later this year, but I can say that they are very likely to have confirmed this trial because I'm now offering MRI-guided radiation to everybody. And so, what we can conclude from this is that MRI-guided radiation did significantly reduce the side effects of the treatment by a pretty significant degree. And this is really because of the precision. We were able to reduce the safety margins that were needed for radiation because of the precision afforded by the MRI-guided device. Just one quick extra thing I'll give a word on is something called radiogenomics, which is a little bit separate, but I wanted to discuss this concept. This is the idea that individual patients may be sensitive or respond differently to radiation, the same way that individual patients might respond differently to medications. Like for giving someone a dose of medication, we might tailor that dose depending on someone's sensitivity. Really should be the same for radiation. I think that makes sense. But do we know that? Do we have proof of that? We've tried to find that. What I'm showing you here is a study that we did. We looked at 93 men we had treated with SBRT for whom we actually had DNA data. We could look into DNA and see if we could find a biomarker that might identify who has more side effects after SBRT and who doesn't. And we found something. And so this curves here are the probability of no toxicity. So if you're at 100% or close to 100%, that means no side effects. If you're dropping lower, that means side effects. And in blue are people who our biomarker predicted were at low risk of toxicity. Indeed, they rarely develop toxicity. This is kind of dropping down, maybe about 5% of them experience toxicity. But for those who were predicted to be at high risk of toxicity, they developed side effects, and they developed side effects pretty early. And down here, you can see that about 55% of patients were experiencing toxicity, pretty early on. This is in days, so less than 3 years after treatment. So, you could say, well, that's only 93 patients, and that's fair. So this is not proof, it's not perfect. Again, our goal here is to try to prove and validate things. So we ran another trial, a 200-patient trial that just recently closed, where we just gave the cheek swab, which this is determined by cheek swab, to patients that were coming and saying they wanted SBRT. The people who were low risk, we proceeded with SBRT. People that were high risk or predicted to have significant side effects, we cautioned against that. But ultimately, if they wanted to do SBRT, they could still choose to do that. And we will be following the results of that very closely. What we would like to see, of course, is that in the patients who are predicted to be at low risk of toxicity, this big group of patients, it will again be something like this, or maybe even better than this. And the patients who were predicted to be at high risk of toxicity, many of them actually did not get SBRT. Some of them did. But the trial is really designed to look at those who were predicted to be at low risk and kind of, are they indeed at low risk? But because of the promising results of our Mirage trial, which is the MRI-guided trial, as well as our preliminary but exciting data about the cheek swab, this is actually how we are practicing here. So if someone comes to me and they decide, they say they want to do SBRT, I do get the cheek swab test. And actually that is something that could be mailed to somebody, because in this era, there's a lot of tele visits and, not in-person visits. And then if they end up deciding to do SBRT, barring some extreme circumstance, we deliver it on the MRI-guided machine. So, while these are things that we investigated on clinical trials, again, it's standard. This is our standard now. We get the cheek swab and we deliver MRI-guided SBRT. We are looking at other things. We're looking at different ways of doing the dose. We're looking at something called adaptive radiotherapy. We're looking at new ways to combine hormone therapy, and other types of integration. But someone that wants to get SBRT, this is the standard workflow that we would be following. So I'd like to thank you for your patience and attention, and I'm happy now to answer any questions that you might have. And so I think, I could answer one that someone had said during the talk. Is SBRT effective at treating someone with intraductal carcinoma? I would say yes, because there's no precedence to think that it wouldn't be. Okay, I can say that there has been a large study looking specifically at patients with intraductal disease, that would be unlikely to have happened, especially since SBRT is pretty new. However, generally it responds the same way to radiation. And as we've seen in these other trials, whether we're looking at high-risk disease, intermediate-risk disease, there's never been a difference in effectiveness. So I don't think there would be any difference. I have treated patients with intraductal carcinoma using SBRT. Now, the second part of that question was, would hormone therapy be recommended? And I would say generally yes. Now, there are some data, they're limited, and they're usually in the context of longer courses of radiation, but they have shown that you get better outcomes when you're adding hormone therapy to radiation in the management of intraductal disease. So that would be my recommendation.
Thank you very much. Am I unmuted, Neil?
Yes, you are.
Dr. Kishan, that was absolutely great. It's really wonderful to hear you talk, and we appreciate your coming. We also want to re-thank Mr. Tim White for making this happen. I've got just a couple little things that in our group, we seem to have several men that would qualify for focal therapy. And I know you've had some experience with focal therapy and the system. The second thing is salvage treatment. And third is we've had a big to do with some of our Kaiser associates about adjuvant, neoadjuvant, or no hormone therapy. Do you have any feeling about that in across the spectrum of disease?
Sure. So I guess I'll talk about focal therapy first. I actually don't do focal therapy. I'm not a believer in doing focal therapy off of a clinical trial, and that's not, there's so many questions to ask and answer in the prostate cancer space. That's not one that I'm looking into. So I've focused my efforts on other things. So I don't think that focal therapy is something that we do with external radiation. It could technically be done, but that's not something that I'm currently offering, nor am I aware of people doing it. Now, there are focal brachytherapy, which is a completely different topic, or in someone that has already had radiation, they have a recurrence, and you're talking about focal therapy in that context is a different story, which we do, but I don't use this device to do focal therapy in the upfront setting.
Okay.
And then the second question, there were a couple of things that came in as well. I think someone did ask that about the, after surgery, what about SBRT in that context? It is investigational. It's just, the first patient treated with SBRT for prostate cancer, definitive treatment was treated in the year 2000. So a long time ago. We have a lot of experience with that. Because in the post-op setting, you're treating a broader area, you're treating a larger area, even if it's a lower dose, and parts of the bladder, parts of the rectum are included in that field. Parts of the bladder and abutting the rectum is included in that field. There's been a lot of hesitation in looking at these more rapid forms of radiation there. We have a 100-patient trial we did in 2018 through 2021 where we looked at SBRT. And we, the results were favorable enough, although short-term, that we launched the second trial where we're looking at SBRT again. These are phase 2 trials. We did find, again, in that context, there was a benefit to using the MRI-guided machine because it can track, in that case, the rectum, which is moving. And so I use the MRI-guided machine when I can in that context as well. But SBRT in the post-op setting, when you're targeting the whole prostate bed, is definitely investigational. I think someone asked, is MRI-guided SBRT covered by Medicare? It is. So, the MRI guidance piece actually doesn't affect the cost as far as the insurer, is concerned, or the payer, I should say, is concerned. It's only if you do things like adaptive radiotherapy, where you are changing the plan and replanning and stuff like that, which is not something that we did, that there might be a billing implication. Otherwise, it's just a different platform for delivering SBRT. So if SBRT by any form is covered, then MRI-guided SBRT would be covered as well. I'll just maybe go through these sequentially, if that's all right. There's a couple of them coming in. Is radiogenomics useful in predicting side effects in salvage radiation for recurrence after surgery? We don't have proof that it is, so it stands to reason that it would be, but you need to develop a marker like that, and so you need a group of men that have good follow-up, that you have their DNA, and you can answer that question. So it's something that we're working on. We do have a cheek swab test, like I mentioned, that we do. And for example, if it suggests someone is sensitive to SBRT, I wouldn't favor treating them on my trial of SBRT in the post-op setting, but it hasn't strictly been studied in that context. After EBRT, the 5-week course, if further radiation therapy is recommended, what would you recommend? I think that depends on what's going on, right? So is it that 5 weeks of radiation were done as an external approach with a plan of doing further radiation? Typically, that's a brachytherapy boost, if that's the case. Our process at UCLA has typically been to do the brachytherapy portion of that first. But regardless, it really depends on what the intent was. If they gave full dose 5-week course of radiation, there's no room to do further radiation, then there's nothing else to do. If they gave 5 weeks of external radiation and it was low dose and you still need extra dose to the prostate, SBRT has been explored in that context. Personally, I don't think there's any advantage to that over just doing everything in 5 days. And so our approach here has just been to do SBRT. But yes, SBRT could be done instead. Let's see. You said there are 2 types of MRGRT. Why did UCLA choose Meridian? The Meridian device is the only one of the 2 that has that real-time monitoring that's automatic. Meaning, if the cancer, if the prostate is moving too much, the beam automatically shuts off. So you really have a much better ability to reduce the margins without like the chance of an operator error or anything like that when it's happening at such a high frequency and in a monitored fashion. So that's why we chose that device. Is UCLA still conducting the lutetium-177 trials? Yes. That's in people with much more advanced prostate cancer. Generally, we are actually working on trials of moving that earlier in the disease setting, but yes, we are exploring lutetium-177. Do you request a PSMA scan before any treatment? It really depends on the risk, the risk of the patient. Meaning, someone with high-risk prostate cancer, sure. I think if it's covered by insurance, we should get it. If it's not covered by insurance, it's challenging, right? Because it can be quite expensive. It can be $2,800, and that could be prohibitive to a lot of people. If it's not prohibitive, if someone has the financial means to pay for that and it's not covered by insurance and they have high-risk prostate cancer, sure, I would recommend the scan. But unfortunately, sometimes that's not possible. Can someone become your telemed patient, obtain a cheek swab sensitivity in context of salvage radiation? I probably wouldn't do that if you're not considering doing so currently, unfortunately, because of the throughput reasons, we're really using the cheek swab test for patients that are likely to receive radiation here. Because it is a test that costs money. We're not billing patients for it, but we're not opening it to people who are not seeking radiation therapy at UCLA. Have you worked with any patients with a current disease following TULSA-PRO or HIFU? Yes to HIFU. No to TULSA-PRO only because TULSA-PRO is so new. I've only had one patient so far that's had coming after a TULSA recurrence, but again, that's just because that's such a new treatment. I'm sure there will be more as time goes on. So yes, you can consider doing SBRT in that context as well. SBRT with MRI for oligometastatic prostate cancer. Sure. Yeah, I mean, we are using it for patients that any patient who's getting radiation to the prostate, if it's possible to do it on the MRI-guided device and that offers a meaningful benefit, we would be doing that. Now, some patients are very claustrophobic. They have metal shrapnel in their body. They can't get an MRI. Of course, we would do the other form of radiation, but if you could get it, we would favor using the MRI-guided device. There are certain situations in which, like I just mentioned, where maybe it's not the optimal, but that's the minority of patients. Someone asked, does prostate radiation have after effects orally? And no, it wouldn't have any. There's no nausea as a side effect of prostate radiation.
Okay, I think that's all of the chat questions.
Doctor, I want to thank you for joining us today for an outstanding presentation and invite you back. We might have some slots open this year. I need to check with Dr. Metzger, but certainly I know we have some slots open next year, and perhaps you and Dr. Metzger can work that out for a full 1 hour presentation on our fourth Thursday of the month meetings.
Sure. I mean, it's a true honor. I love talking with patients. I'm happy to answer any questions, and yeah, I would love to come.
And Dr. Kishan, I think we have one more question from Adam that would like to ask you verbally.
Okay, sure.
Hi, Dr. Kishan. Thank you very much for everything you've imparted to us. I was talking with Dr. Metzger. Thank you, Dr. Metzger, for taking the time to answer my emails and see my results and everything. And he had said that I should ask you directly. I have recurring prostate cancer. It's 0.05 last September. It's now gone to 0.07. The recommendation is hormone therapy and then radiation. And I was told that now they're thinking radiation might be better before the hormone therapy. But most importantly, should I have the PSMA to find out whether it has gone outside of that area rather than them just firing into there, because that's what they've been doing for the last X number of years?
Yeah, so it's a complicated question. It's a good question. The PSMA is unlikely to show anything in a PSA of 0.07. So just for context, even at 0.2, the chance of finding something on a PSMA scan is about 20 to 30%. And that's because no scan is perfect. It's the best scan we have, but its resolution limit is 3 millimeters, and individual cancer cells are much smaller than that. So you would, in all likelihood, have a completely negative PSMA scan. That doesn't mean there's nothing there. It just means it's too small for us to see. And it is an interesting question. Well, shouldn't we wait until we can find something? The risk that you run with that is if it ends up being in the prostate bed anyway, you've just let it grow, right? And it kind of makes sense that the smaller the mass, the lower the amount of PSA, the less cancer there is, the more likely it is to be cured by radiation. So, when I'm counseling my patients, I would say, there is a window within which it's okay to wait. Technically, some people have said 0.2, right? But if I'm seeing a patient that has a PSA of 0.2, we get a PSMA scan, it's 0, I wouldn't say, oh, well, that means we don't have to treat you. We just should wait until it shows something. That would be experimental, actually. The standard would be to just proceed with treatment, even though the PSMA didn't show anything, because we know there's something, and we use clinical judgment factors, which I'm assuming your physician did, to assume that it's in the prostate bed or potentially in the pelvic lymph nodes. I would need a lot more information. The comment on hormone therapy, that's a whole different topic, a lot of nuances there. I hope that your physician is probably considering all these things that you think about, like the Gleason score, the timing, the doubling time. There are things like the Decipher test. There's things that can go into the decision to add hormone therapy to the radiation in the postoperative setting. And I don't have that information, so I don't know. But hopefully, yes. I mean, that sounds like a reasonable approach. And then I think you were asking about the sequencing of the hormone therapy, and the best data we have for that is in the case of intact prostate cancer, where there's data that we've published and will be publishing that suggests that it is more important to have a longer portion of the hormone therapy after the radiation is completed. That might be more advantageous than having it front loaded. But it's not it's not like it's a terrible thing if you had 2 months beforehand, 2 months during the course of radiation, and then 2 months afterwards. I don't think it's a great idea to give like 5 months before we do the radiation or 6 months before we do the radiation and then do the radiation. It's better to afterload it if possible. But that has been best studied in the case of someone that has the prostate in place, not in someone that's had the surgery, where there's much less data to guide that.
Okay, and you had mentioned the 0.2. The last couple of things I've read, and I've learned I got to stop reading. It had said when it's at 0.02, that the chances are better, but at 0.04 or 0.05, it's 4 times as likely for it to not work, or for it.
I think those are times 100. So or times 10, sorry. So it's at 0.4 and 0.5. So the late salvage has been defined as 0.5. It might also depend on the units of your PSA, right? It's typically in nanograms per deciliter, but some labs might report it differently, which can make it confusing. Okay. But I mean, it's certainly not true that it's 5 times less effective going from 0.02 to 0.05. It is much less effective going from 0.2 to 0.5.
Okay, good. Thank you very much. Appreciate that. I might have misread it. I'll go back and look at those numbers. But hey, thanks. Makes me feel a lot better.
Okay.
Okay, and then just one really last question I saw in there. How does SBRT compare to HDR? So I think they're both highly effective treatments. I think there's the HDR is certainly a good treatment. It's been around for a long time. One difference is there might be a little bit more, or I should say there will be a little bit more urinary dose because the urethra running to the center of the prostate is going to be exposed to a higher dose of radiation with the inside out approach. Conversely, there might be less dose to the rectum with HDR than with SBRT because of the inside out phenomenon. But as we've seen with these modern radiation technologies, the dose outside of the prostate is really quite limited. And we didn't even see any moderate GI toxicity with the MRI-guided approach. So, my bias obviously would be towards SBRT, but HDR is an excellent and long-standing, well-established treatment modality as well.
What is the difference between SBRT and SBRT and HDR plus external? If you add external to it, is there much of a difference in cure?
So SBRT is a form of external beam radiation. The combining SBRT and HDR really should be done in some kind of a clinical trial.
I mean SBRT plus IMRT.
Yeah, I don't think there's any advantage to doing that. So SBRT can accomplish the same thing as like a 5-week course of IMRT plus SBRT. So there's no need to do it that way. So I don't use SBRT as a boost. Some people do, but I think there's no need to do that. You can just do SBRT by itself.
Okay, I think we're done with this portion. Thank you so much again. We can't tell you how much we appreciate your coming on and sharing all this information. And give us a lot of food for thought. I think you mentioned that the prostate is a moving target. That sounds like some line from my ex-wife's divorce settlement, but that's another topic we won't get into tonight. So certainly appreciate your coming on, and thank you again.
Of course. All right, take care. Bye.
Bye-bye.